Thank you all for staying to the bitter end. It's been a long day, but it's been great. So I'm here to talk about a kind of two-part pilot study that we did in Kumasi, assessing client and provider perspectives on family planning needs at Kumasi. And this was a collaboration between the University of Michigan and Kumasi Teaching Hospital, departments of OB/GYN. So for this part, we conducted semi-structured interviews with core healthcare providers recruited from two clinics out of Confidential. One was a BCT clinic, and another one was the ARV clinic. And we conducted a total of 15 interviews. 5 were with BCT providers and 10 were with ARV providers. And the purpose of these interviews were to assess these 4 main topics. So we wanted to look at current practices and attitudes with regards to family planning. We wanted to assess the current relationships between the family planning clinics and the HIV clinics, as well as perceived barriers to integration and potential pathways to integration as well. And these interviews were transcribed and analyzed. So this was the overall kind of framework that we came up with from these interviews. So kind of to start off with, we kind of put together what the current state of things were. So available services. All providers reported providing counseling with regards to family planning. Most commonly, they reported discussing condoms and sticking to an ABC model. No providers reported a formal relationship with the family planning clinics, but most of them said that they would occasionally provide informal referrals to family planning, and there was a formal referral system set up for pregnant women to be referred to the PMTCT clinics. And then also we looked at kind of the perception of client needs from the providers. And so we kind of compared this as well to what we heard from the clients, and that's in a separate poster. But overall, some of the providers felt that there was a low need for contraception. And they also identified a reluctance, or perceived reluctance on the part of the clients to discuss sex and sexual health matters with their HIV providers. And then from all these, the providers identified some barriers, perceived barriers for integration. So kind of the main one, which I'm sure is pretty common, is time. And so this was time from the perspective of the providers and overall clinic time, but also client time. They cited specifically long wait times with regards to visits to get their HIV care, and then having to be referred to another clinic, and then long wait times there as well. Stigma was a common theme that came up, and this was stigma on many levels. Stigma with regards to the so family planning stigma from the HIV providers, and then HIV stigma from the family planning providers, as well as a lot of client self-stigma with regards to their HIV status. Another barrier that was identified was misinformation, generally client misinformation, but then also misinformation among the general public with regards to family planning. And then clinic goals. There were actually a few providers at both clinics that said that family planning, provision of family planning was not necessarily aligned with their specific clinic goals. And then one provider interestingly brought up language. And this was, he elaborated to say that, so most of the clients that come to these clinics speak Twi, the local language there, and that he said that there wasn't an adequate vocabulary in Twi to really discuss thoroughly family planning and contraception issues. And then finally, there were a number of proposed solutions that were identified. One was simply to improve collaboration between HIV clinics and family planning clinics, and communication overall between the providers. Another common suggestion was to identify a representative or kind of a key point person to act as a liaison between the family planning world and the HIV world. And then overall patient and provider education with regards to family planning. And then kind of the Many providers suggested having a family planning provider provide on-site services at these Asian clinics.
Thank you very much, Angie. And now our final speaker is Telstra New Zealand.
Good afternoon, ladies and gentlemen. I'm Fosh Muzila, medical doctor from Mozambique. I'm going to talk about the integration of maternal and child health with HIV service and care at community level in rural Mozambique. I can't talk about this project without mentioning community antiretroviral therapy groups, which are groups of 6 people who live in the same area, okay, and take antiretroviral therapy for treatment of HIV. One group member collect and distribute ARP each month to grab member in the community. Methods. During 2011, an operational research was developed in Xangara district in the center of Mozambique using a quantitative and qualitative baseline assessment, intervention, and the evaluation of initial results about use of mother and child health service among community ART group members and their families. As a result of this baseline assessment, we found that there was a good utilization of HIV care, antenatal care and delivery, vaccination of child, prevention mother to child transmission care, HIV exposed infants. We also found that there were some difficulties with VCT for members of family aggregates. Also found difficulty in family planning, tetanus vaccination in women of fertile age, nutritional for child, and ERT for child. And as a result of this baseline assessments, we analyzed and implemented interventions. Dual intervention was set up to strengthen knowledge and grasp of maternal and childhood health personnel, and to establishes a group of 15 women and 40 men as knowledge intermediaries from the community and the groups to promote maternal and child health service and liaison with health service. We trained intermediaries from the GAC, community arts, ART groups, to follow up women and women in fertile age and children in the areas of family planning counseling, nutritional promotion, and visiting in the community. Following the slide showed the group, often made out of community ERT groups during their training, and also a kit of cook demonstration.